Thank you for your kind introduction. I think this is a wonderful initiative. I wish you every success, and I'm delighted to be participating in it today. I feel I'm speaking to a diverse audience, and so I'm going to speak about what I think is a common denominator, which is data. And the message I'm going to, let me start this. Good. The message I'm going to try and convey is that, as we all know, clinical care needs research and audit, which requires adequate data registries, a sound infrastructure, best managed by data managers, leaving clinicians to do the clinical work and to reflect on the new data and new information and to provide new knowledge, ask questions, and improve care. So that's my message, which I'll try and support. I became involved in data because I wanted to make sure I wasn't killing my patients. And that's because I was accused of being a murderer by a very famous Dutch pathologist, Professor Manschot. And he made that accusation because I was doing these exoresections, making a trapdoor in the eye and removing the tumour from under the retina and putting the eye back together again, under the mentorship of Professor Folds. Here's a video to show you what it involves. And for the ophthalmologists, the trick here, the tumour is going anterior to aura. So if you just do a cyclochoroidectomy, you'll end up with a big retinal dialysis and retinal detachment. So the objective is to conserve the ciliary epithelium in the pars plana, which is only 2 cells thick. And this is how it's done. First you go into you go through choroid over the retina, which is nice and strong, much stronger than ciliary epithelium. And then by blunt dissection, you separate the choroid from the ciliary epithelium and excise the tumour. This is done after softening the eye with a vitrectomy. Look, the pars plana epithelium is intact, as you can see. And the systolic blood pressure is about 50 or 60. I was very lucky to have the same anesthesist every week for many, many years. I always laughed at his jokes so that he'd lower the blood pressure for me. And that's it, that's what's done. And that's why I was accused of murdering my patients. And that is because at that time, the standard treatment for intraocular melanoma was removal of the eye, enucleation. And not just enucleation, but all sorts of measures were taken to prevent scattering the tumor cells during the procedure. So, for instance, patients received pre-enucleation radiotherapy, or first the eye was frozen with cryotherapy so that all the tumor cells would remain there, or things like that. And it was assumed that if the patient rubbed the eye, or if you did the enucleation roughly, you'd scatter tumor cells and kill the patient. And that's why people condemned that. So that's why I got involved in data. And last week, in preparation for this meeting, I spent an evening matching up a whole lot of patients treated by enucleation and those treated by local resection, exoresection, according to age and tumor size. And you can see the survival is the same in both groups. So I don't think I'm killing my patients after all. Tumors don't behave like dandelions. They behave like bee colonies. As soon as the queen bee decides to swarm, it swarms. As soon as a melanoma develops monosomy 3, it metastasizes. And I had the same problem with endoresection, where you go in with a vitreous cutter and you nibble the tumor into little bits and you suck up all the bits and you hope you don't leave any behind. And here's a patient from Australia, referred by Mike Giblin. And I'm still amazed that he was able to judge this so well that this patient would be suitable for endoresection, because the patient was a fanatical golfer, as most golfers I think seem to be. And he was prepared to travel all the way to England to save his vision so he could continue playing golf. And I'm told that after all these many years, the patient still has 6/5 vision unaided. Is that true? But people were condemning me for doing this operation, even though I published the results. There was Professor de Jong from the Netherlands, and he said, look, you're going to get into big trouble doing this operation because other people are going to try this operation, they're going to get bad results, they're going to blame you. And sure enough, these ophthalmologists, famous ophthalmologists, condemned me for doing this operation, especially Professor Jewson from Berlin. Only 2 weeks ago, I was at a meeting in London organized by the Ophthalmic Oncology Group, and she said explicitly that if you do endoresection, you're going to kill all your patients. So, luckily, I've been invited to debate against her in September in Paris on this matter. And because of this group, here's a patient from New Zealand, a pilot, and he had read these papers, and he insisted on pre-endoresection radiotherapy. And the endoresection was entirely successful, but because of the radiotherapy, he lost the vision in that eye. So a lot of patients are losing vision unnecessarily because of this philosophy of pre-endoresection radiotherapy. And anyway, I did my analysis, and so far the survival is the same. Endoresection is very useful after radiotherapy. We think of radiation retinopathy as being caused directly by the radiation, but a lot of the morbidity is caused by the presence of the tumor, the irradiated tumor. And so I coined the term toxic tumor syndrome to summarize exudation, retinal detachment, retinal ischemia, neovascular glaucoma, painful eye, and so on. And this shows that endoresection can be very good at removing a posterior tumor and removing the toxic tumor. And here's another patient whose toxic tumor syndrome was successfully treated by exoresection. He had had a stroke, and so I wasn't able to do I didn't do an exoresection because I didn't want to lower his blood pressure. And then he got this, and he was amblyopic in the other eye. So I removed the tumor without lowering the blood pressure too much. And his retinal detachment was flat. His retina was flat the next day. His neovascularization resolved, and his glaucoma disappeared, so that after a few months, he didn't need any more drops. Proof of principle. So for small tumors, laser treatment is very good. Here's a patient who had proton beam radiotherapy with macular detachment. Nothing worked. PDT, Avastin, repeatedly, and then the patient had transpupillary thermotherapy, and within a month everything was fine and the vision came back to normal. So it's really important to remember the toxicity. So when I started the data management, I got a small grant, employed an IT person to make a database, employed a data manager, but the project failed because I had to stay behind after work to fill in these forms, and it was exhausting. Then a patient gave me a large donation, and I was able to employ Andrew Macaulay around 1990. And he made this wonderful database that's still going strong back in Liverpool today. And I turned the clinic into a clinical laboratory, and I was able to update the database as I saw the patients. But I didn't have time to get the pathology data, the survival data, all these things. And then about 1995, I had a meeting with my clinical director and my appraisal. And what you're supposed to do at these meetings is to say how you're going to improve yourself over the next year. And I said, I need to go to Boston to see how they do proton beam treatment there. And so the hospital paid for me to go to Boston for a week. And over there I saw a room full of data managers. So when I went back to Liverpool, I told the hospital, I said, in America they've got data managers, why don't we? And so the hospital paid for a data manager full-time permanently, and no questions asked. And that transformed my career, my practice. The hospital didn't ask where the funding came from, so I didn't need to tell them it was from research grants because they never asked. Just as they employed a secretary, they employed a data manager. And that was so useful that without me asking, they ended up employing a backup in case something happened to the first one. So I designed these proformas with paper notes, which were identical to what was on the screen, and like that was easy for the data manager to see what to computerize. And that led to lots of innovations that would otherwise have been impossible. Proton beam radiotherapy for iris melanomas, transpalpebral radiotherapy for superior choroidal melanomas. If you try to retract the lid and you don't succeed and you irradiate the upper lid margin, you get keratinization, which scratches the cornea, causes terrific keratopathy, and you can avoid all those by treating through the closed eye. And eccentric plaque placement. That's a very successful result. It looks as if we've missed a bit of the tumor, but we haven't, because the radiation goes beyond the visible choroidal atrophy. And that's using a template that I designed, which allows transillumination and very accurate placement. I'm not getting any funding for that. And it allowed a study on 2,500 patients where we found that 1 in 5 symptomatic patients with melanoma had their tumor missed by their optometrist or general ophthalmologist or whoever. And those patients were much more likely to need to have the eye removed. And another study, did I miss a slide? Yeah. And that really was a very important study because it helped us to educate people in the community, not just to look at the disc and macula, but to examine the entire fundus. Another really important paper was this one published by a German group, Prescher et al. In 1996. And this group showed that the only patients who get metastasis are those whose tumor develops monosomy 3. Otherwise, the survival is excellent. And when I saw this paper, I went to my hospital and I said, look, if our patients ever found out that we were only treating their eye and doing nothing for their survival, they would never forgive us. And so the hospital paid for a full-time postdoctoral research fellow to translate this into clinical practice. And we had Andrea Scholes. She confirmed the German results. And by 1999, we were offering genetic tumor typing to our patients as a routine clinical service. And we had to audit it. We did that, and then we developed MLPA, which was much better. And with all the data that we had over many years, we had 3,500 patients who were able to develop this prognostic tool. Because once we had the data, the mathematicians came running after us because they needed good data to test their techniques and to develop their statistical techniques. And so there's this online tool for estimating prognosis according to tumor size, tumor stage, genetic type, and histologic features, taking age and sex into account. But we're able to do this also because the NHS Cancer Registry automatically informed us of the date and cause of any deaths. Every month we got a list of patients who died and the cause of death. Otherwise, we would not have been able to do this study. And that's because when I first started, I designed a consent form and every patient signed that consent form. I had some problems with the ethics committee because they didn't like the idea of an open-ended consent for future studies that you didn't know you were going to perform. But luckily I convinced them and they agreed. And that was a good thing because after about 10 years, the cancer registry said, oh, we're going to have to stop giving you your survival data because you don't have the consent of your patients for us to communicate with you. I said, but they're my patients. I said, it doesn't matter. We can't tell you your patient's survival. I said, because you don't have consent. I said, oh yes, we do have consent. Here it is. And so they were able to continue to give us consent. And recently I found this, that the National Institute of Health has got and is advocating this broad consent to make research, to make consent future-proof for future trials. And because we were able to identify very precisely which patients are going to get metastasis, we were able to to do MRI scans on those high-risk patients. Without this prognostication, without the genetic typing, it would have been impossible to target these expensive tests at these high-risk patients. But we were able to do so, and it was cost-effective. But every year we're finding new mutations that are really relevant to uveal melanoma. And so the technology is improving all the time, and this prognostication needs really, really good genetic analysis. And so the first thing that happened when I moved to San Francisco in 2013 was that I knocked on the door of Boris Bastian, who's a professor of molecular pathology. And he had just developed this UCSF 500 next generation sequencing kit. And so we got a grant from our hospital and evaluated it on about 60 patients. And it's working beautifully well with very small samples that you can get from biopsies. And that's what we're using at UCSF now. And because we can get good genetic data from smaller and smaller samples successfully, and because the genetic information is so important, that justifies invasive techniques like biopsy. One thing leads to the next. So here's a patient who is 84 with a tumor that's growing slowly. Should we just leave it and hope for the best? What if it's a monosomy 3 melanoma and she gets metastasis? Then we'll all think we should have treated it. So we did a biopsy, even though the tumor was very thin and very anterior. My colleague there, Armin Afshar, who's now succeeded me, was able to biopsy it. It showed monosomy 3, and so we treated it. Everybody's got peace of mind that we've done everything possible to prevent metastasis. Now, a lot of people say, well, what's the point in doing biopsies, doing genetic analysis, doing screening for metastasis, if you can't do anything about it? Metastases are untreatable anyway. Well, I've always done all this because in preparation for the day when we would have some effective treatment for metastasis. So I was really excited when I saw these results when I was still in San Francisco, how uveal metastases are really responding very nicely to this drug, IMCGP100. It's got some side effects like skin rashes, hypotension, but they seem to be transient and not very severe. And according to this study, the patients who get the skin rashes, just like with some other forms of treatment, are the ones who do best with this drug. And this study by Garvan and others shows that about 75% of patients with this agent were still alive after about 2 years. And these results are really, really encouraging. So when I moved to Oxford, back from San Francisco, and I was at a meeting and I met the people from Immunocore, and I'm working as a part-time consultant with them. And so that's a declaration of interest. And this is a bispecific kind of drug. And it's got a T-cell receptor at one end and a sort of antibody at the other end. So that it links up lymphocytes, T lymphocytes, to the melanoma cells so that they die, they're killed. So you've got the GP100, which links up to HLA-0201, so it only works in about 50% of patients. You've got to have tissue typing first. And then there's the GP100 with the HLA, and the T cells ignore the melanoma cells because there isn't enough, they're not antigenic enough. But with this drug, it links the T cells to the melanoma cells and induces them to release the hydrolytic enzymes which kill the melanoma cell, and then the T cell is free to kill another melanoma cell. So you don't have to extract tumor-infiltrating lymphocytes and harvest them and so on. This drug uses the lymphocytes that are already present in the body. So on the right is a video that I'm going to show. The red cells are the melanoma cells expressing GP100. The gray cells are control cells. The yellow spots are the lymphocytes. And if I can get this to work, you can see the lymphocytes killing the melanoma cells without killing the other cells. And for me, it's just what I've been wanting to see most of my career. There we go. So a lot of this has been possible because we've had special funding from the National Health Service, which had an organization looking after rare diseases, just like MAST here, just like what's happening in Australia, which I was delighted to hear about. So it's got to be a disease where there's less than 500 patients needing a particular treatment, the whole of the United Kingdom. And I applied for this funding for lots of forms, and because of what we had already done, we got recognized as a center to be funded for this. And on the strength of my application, London and Sheffield got a similar support. But we had to meet lots and lots of specifications. On the right, up top right, you can see Jane Humphreys with all the evidence that she had to collect for us to get that special support. And then on the right, you can see one of our MDT meetings that we used to have every Monday. What used to happen was, what still happens, is the patients travel to Liverpool on Sunday, stay at a hotel, we pay for the hotel and the transport. Monday morning, they see the ocular oncologist. Monday afternoon, they get their tests and see the anaesthetist. And if they need a biopsy, that's when they have it, or Tuesday morning. And then Tuesday morning, they have their surgery. And by the next weekend, they're home, treatment completed. And but we had lots of standards to fill in. One was that we had to have MDT meetings to discuss each patient. And every year, we had to have a grand MDT meeting. And I perverted it into a meeting like this, where we had all the radiotherapists, oncologists, geneticists, pathologists, everyone involved. And I also invited an external assessor who came a few days before, inspected our department, spoke to patients, opened all the drawers, asked us lots of questions, and then wrote a report on the performance of our hospital. And that's proved to be a very valuable experience. One of the specifications is that we had to have nurses with special training. And eventually we had 4 nurses. And they really played an enormous role in keeping things going, providing telephone support, counseling, all sorts of things. They even had a nurse-run ocular oncology clinic. Because I was getting 850 new patients a year, I had to discharge 850 patients a year. And many patients didn't want to stop coming. They didn't need to come anymore because their tumor was dead and had been dead for years. But they didn't want to stop coming. And so we set up this nurse-run clinic, and we audited it and published our results, and it was a big success without any doctors involved. There were doctors nearby in case any help was needed, and so that just shows the kind of role the nurses played. Another standard was that we had to collect certain data, and we had to analyze it, whether we liked it or not, and we had to have national audits. We were very lucky that we had an infrastructure to do this, but other hospitals were less fortunate, and so it was more difficult. But we did have UK guidelines, and it's great to see guidelines coming from Australia too, which are influencing care worldwide, not just in Australia. There's a big emphasis on communicating with patients and giving them psychological support, and so we published a book, that 70-page book that each patient got before they arrived at the hospital. Every patient got an audio recording, a new patient got an audio recording of the consultation, and every patient was visited by a health psychologist to give them emotional support and everything. And I said we had a second data manager, but the first data manager didn't like it because he was very possessive of his data. So I had to keep a second data manager busy without interfering with the first data manager. So I gave her the job of auditing patient satisfaction and quality of life. And I forgot all about it, more or less. And the psychologist was involved too, and they advised. And then after 20 years, I was able to harvest all the data that had been accumulating over many, many years. And we were able to do quality of life studies in 1,500 patients. And many patients had had completed questionnaires once a year for many years, and so we're able to look at change over time and compare nucleation with radiotherapy, and I'll be speaking about this tomorrow. The big positive thing is that the patients who had their eye removed were just as happy as the ones who had radiotherapy, except that a lot of patients needed to have the eye removed because they presented late. And they presented late because they had domestic problems, social problems, financial problems, various other problems. And those were the things that were lowering quality of life, not so much the type of treatment that they received. So this was really very educational for us, and it's just been published. So having more papers brought more patients, and more patients got more tissues, had a tissue bank. And so we're able to start this. And there's Professor Sarah Copeland from Australia, who's built up a very successful team of basic scientists doing basic research. But a lot of this research is possible. Tissues are worthless unless they come with clinical data. You want to know the tumor size, the age of the patient, gender of the patient. You want to know the survival. And like that, you're able to do much more research than if you only have a piece of tissue with no consent and nothing at all. So that's going very well indeed. Then I moved to San Francisco, where there was nothing, because my predecessor had gone some time before and everything sort of finished, and my job was to start it all up again. But the IT department set up a really good database, a registry in our electronic patient system, very successful, excellent. And we're able to do studies on retinal lymphoma very successfully, and retinoblastoma, which I really needed to audit because I didn't have much experience in treating retinoblastoma. So this gave me the confidence to know how I was doing. These were like headlights in the dark, driving in the dark, and with this data I was able to see where we were going, how we were doing. And these two studies were successful because we had a data manager with a grant from a patient, well, not with a grant, and a scribe who acted as a data manager. And so we had everything computerized. We were able to do a lot. And then I tried to do this study on quality of life. And the IT department collaborated with this private company, Vision Tree, which sent out questionnaires to patients automatically and reminders automatically. And the quality of life data were merged with the clinical data that were extracted from our electronic records. And I was going great. And then our data manager, her contract finished. We couldn't get a replacement. The whole project collapsed. So just because we lost our data manager. So the American Academy of Ophthalmology has developed IRIS, Intelligent Research Insights, where the data are extracted automatically from the electronic medical records without the doctor needing to do anything at all. And I was given a month's data. I went to Dr. Park's talk. He spoke at our weekly meeting, and I immediately went to the headquarters of the American Academy of Ophthalmology, just a 5-minute walk from where I was living at the time in San Francisco. And I had meetings with them and set up, got in touch with IT at UCSF, and we got it all to work. It took a long time because of legal issues, because some of the data were leaving the United States and then going back to the United States, and that was forbidden. So it had to be changed. And I was able to extract data from our records and look at the age of the patients, the intraocular pressures, and the number, the differential diet. It all worked really well. But then the hospital changed its priorities and had to meet some specifications of its own, and so the project died. But it's all feasible. But the trouble with that is that it doesn't get pathology data, it doesn't get survival data, all sorts of things. So you have to have a data manager even with that system. At Oxford, my job my current research interest is to solve the nevus problem. We're overwhelmed by vast numbers of referrals with nevi, taking up precious hospital resources. And so I've developed a mnemonic, moles, to distinguish moles from melanomas. And now my job, what I'm trying to do is to see whether that works or not, whether the scoring system works. And I've got an atlas on the internet to help optometrists and people in the community to diagnose these things. But I don't have a database, and I don't have a database manager, at least not yet. You have to have a critical mass to justify these resources. So I've devised a system where I've got a specimen patient, and when I dictate a letter, I recite those words. And then when the letter gets done, I cut and paste it into Excel, and Excel expands it all out, fills up all the columns with tumor dimensions, age of patient, everything, because of the keywords that I've used. And so I'm able to do these studies on location of nevi, diameter, clinical features, and so on. But again, I need a data manager, but I need to justify a data manager by having one. With regards to more multi-center collaboration, the European Ophthalmic Oncology Group has been very, very successful. I was one of the founding committee members in 1991. We meet every 6 months. We do collaborative studies. And we met just a couple of weeks ago. And one of the keys to success is having a coordinator to organize the meetings, prepare the agendas, and do everything. Funded by patient donations, originally, and now funded by subscriptions, the registration fees and so on. We have to pay 30 euros a year to be members of this, which is nothing. One of the key successes is collecting data on about 7,000 patients to update the TNM staging system. And that was successful because it was really easy to send a file with anonymized patient data and just send one Excel spreadsheet with 3,500 patients in an evening. But I was also involved in this TNM study, and I helped design the database there. But I didn't have time to send them any patient data, because despite my advice, even if you had data on lots of patients, you had to key it all into this online registry all over again, and there just wasn't time to do that. So other people who didn't have so many patients were able to do it, but I wasn't able to do it. So lots of scope for improvement in melanoma treatment, cutaneous melanoma treatment, because the published literature has such high failure rates. So we've audited that using our data registries and devising a system for scoring in situ disease. But we've also gained a lot from our patients. I've worked closely with patient groups in Britain and the United States, different patient groups. And tomorrow I'll be speaking about a survey which looked at patients from all over the United States and what made them happy and more importantly, what made them unhappy, what they would have liked to happen in their care which they did not receive. And our patients are ganging up together internationally. They've got expectations. They get very upset, and rightly so, if we don't meet their expectations. In the United States, they want a registry. They're designing a registry. I've helped them design a registry. And if the collaboration, not just amongst ophthalmologists dispersed around the country or around the world, but also collaboration with patients can be really, really powerful. So in conclusion, in a roundabout way, we've looked at different aspects of uveal melanoma, detection, diagnosis, prognostication, treatment, a few words about conjunctival melanoma, data, databases. And I'll conclude as I started, that to address important questions, we need multi-center collaboration, we need data provided by data managers, not clinicians. We've got other things that we must focus on, generating good quality data, thinking about how to do so, analyzing the data, thinking about the data, asking questions, and generating new research. So I'd like to acknowledge my colleagues in England and the United States, and I'd like to thank you for your attention. Thank you very much.
Thank you very much. I'll just open the floor for questions. you. That was a great talk. My name's Jody Rich. I'm going to be talking tomorrow about the AURA trial. I was really interested in what you were saying about GP100. I was just at a conference in New Orleans a couple of weeks ago, and GP100 is becoming a poster child for IO. Have you thought about using GP100 as an ocular injection, given it's had such great success in the rest of the body? Why wouldn't we use it to actually treat the primary tumour in the eye?
Yeah. I'm not the right person to address that question. Our chair is a much better person. I'm just a simple surgeon. I cut out tumors and laser them and kill them and all the rest of it. But importantly, I provide data to the basic scientists who want to address precisely that question. And I help, at the moment I'm helping Immunocore that's developed a drug originally started at the University of Oxford, where I'm working, which does attack GP100. My understanding as an amateur in basic science is that GP100 is expressed in minimal amounts on the cell surface, not enough to stimulate a strong immune response. But this drug that's been prepared greatly amplifies the attraction of lymphocytes to this antigen, so that the T lymphocytes and other lymphocytes do attack the melanoma cells. So it's doing what you're suggesting in a sort of roundabout way.
Yeah, I mean, I think that, Jody, the obstacles to doing that are firstly translational, so there have to be some sort of evidence from mouse models that this might work, given issues with immune penetration into the eye. And then there's also financial obstacles as well. So even if they did some nice mouse work, convincing the company that they're to do this when they've got a registrational trial with the FDA, where if imagine they do this and the patient goes blind because it suddenly sucks up all the GP100 in all the choroid, will be a major safety signal, and then may cause issues with their drug if the registrational trial is successful. So there would have to be a lot of preliminary work up to that point where you could convince a company from a financial and regulatory point of view, when they don't even have an approval in place yet, they're going to take a risk by injecting something into someone's eye. There may be patients on that trial who have their primaries in situ, and so it may be interesting to go back to the company and say, of those patients who have the primary in situ, have you seen any evidence for activity? And then work at it through that angle, orthogonally through that angle, and may get some traction with them commercially and also scientifically to do more work. But I don't know how many patients on that study would have had their primary still in situ off the top of my head. Anyone else have any comments or questions?
I was going to say, some of the reported data is that less than 1% of patients when they present with their ocular melanoma have metastatic disease. But that's very uncommon as an ocular melanoma.
Yeah.
But it does occur. It's certainly something that we should all be looking at. What happens to those patients once they occur? As Bertil has said, I think that one of the things about what we have to do is that we need to improve survival. That's adding local people, local treatment.
There's certainly patients who have PET scans where you can see the primary in the eye, and if those patients say they're refractory to the plaque, and then you give them the GP100 because their primary is growing simultaneously with their metastatic disease, and you see the primary shrink, that may be the sort of data the company will go, wow, and then they may invest in that. Anyone else?
Thanks again for a great talk. I want to ask a different question, and you've given us great insight into things like collecting data and analysis, and particularly impressive is the support given in the UK for this rare disease. Do you have an idea of what a critical mass of cases would be for a centre seeing ocular melanomas? In other words, how do we justify building centres of excellence, and how can we, say that, X number of cases should be seen and centralised to improve outcomes?
Yeah, it's a very good question. Well, I did my training, postgraduate training in Glasgow with Professor Folds, and I was very happy there, but we're seeing only 60 patients a year. And I knew that I wasn't going to get very far with only 60 patients a year, because you need large numbers in order to have the right p-values in any statistical test that you do. And that's one of the main reasons why I moved to Liverpool, so that I'd be in the centre of Britain, of the British Isles, and so the number would increase. And the number of patients trebled very quickly and kept increasing after that. And like that, I was able to achieve more in a shorter time. Whereas over here, I've seen over the years how well the ocular oncologists get on with each other and collaborate. I've seen the way they share cases when they're not sure of a diagnosis on the internet, which is absolutely fantastic. And if data can be pooled and if authorship can be shared and all that kind of thing, I can see a lot of rapid progress happening here. But what did local ophthalmologists say about that? Because with a population of 25 million, it's probably about the same size of the population that I served in England.
Yeah, John McKenzie from Melbourne. I'd just like to answer that question a little bit from a different perspective, and that's the perspective of those who treat retinoblastoma. And we now have a group that has also formed an alliance, and that's because we have a number of state centres that treat this, but yet we only treat 25 new patients per year. And you could certainly make a strong argument if you were to say, how do we have a centre of excellence? You don't divide it 25 patients up between a number of different centres. So to start with, we've started a benchmarking group, and the idea there is that if you're going to be treating these diseases, one of the things you've got to do is provide some data. If you don't provide your data, then realistically you shouldn't be doing these sorts of therapies, because then no one actually knows what goes on. That's led to, in Adelaide at the moment, they don't have anyone who's been fully trained, so we're seeing those patients in Melbourne in conjunction with some Adelaide clinicians. And I think that the reality of Australia is that we've got widely spaced patient groups. They are, I think, largely referred to the ocular oncology treatment centres, and I think that one of the things that we've got to do is have data that we can do benchmarking on. I think that's the take-home message, and it's something that certainly we've done for retinoblastomas.
Okay. Is there any time for one last burning question, otherwise we'll move on for Ellen's talk? Great. Well, thank you very much, Bertil.
Okay.